So ODYSSEY was a randomized trial in 18,924 patients with recent acute coronary syndrome who were already on maximally tolerated statin therapy and were then randomized to alirocumab and placebo. And alirocumab is one of the PCSK9 inhibitors. And after a follow-up of 2.8 years, there was a 15% overall risk reduction in major adverse cardiovascular events, which translated to about a 1.6% absolute risk reduction. Okay, so the kind of premise behind this is that we know that Lp(a), which is an LDL cholesterol type lipoprotein particle, but has an Apo(a) stuck on top of it. So we're now pretty convinced that it's a risk factor because there have been Mendelian randomization studies that suggest that if you have a gene that gives you high levels, then you have a higher risk of events. And so it is less clear whether that's true among people who already have coronary disease. So we wanted to find out, number one, whether Lp(a) was a risk factor in this population. Then we wanted to find out how much of an impact alirocumab has on Lp(a), whether alirocumab treatment effect depended at all on what your baseline Lp(a) level was. And then the most important part was to try and sort out from a compound that lowers LDL cholesterol and lowers Lp(a), how much of the risk reduction is mediated by these two effects. So that basically summarizes the rationale for what we did. And so we found, number one, that Lp(a) is a strong risk factor for major adverse cardiovascular events, even in people that get standard of care treatment for their coronary disease after they had an acute coronary syndrome. We learned that if you have higher Lp(a) baseline levels, then you're at higher risk, and so the risk reduction that you get with alirocumab is higher. We learned that alirocumab lowers Lp(a), and that depends critically on at what level you start. So the higher your baseline Lp(a) is, the more lowering you get. And then again, the most important part of the analysis was to try and sort out whether it's LDL lowering or Lp(a) that drives the event reduction. And so regardless of Lp(a) level, LDL cholesterol lowering is kind of the dominant factor that drives event reduction. But as you go from low Lp(a) to high Lp(a), the proportion that's due to the Lp(a) reduction increases. And so when we just look at the upper quartile of Lp(a), 27% of the overall reduction in major adverse cardiovascular events is attributed to the Lp(a) reduction, 73% to the LDL reduction. And that suggests that in people with high Lp(a), that actually may be a meaningful clinical impact. Yeah, I mean, I think, since this is a sub-analysis of a randomized trial, I don't think it is something that will change practice, tomorrow. But I think it should sensitize the clinician that there is still risk in people even that are optimally treated by the current guidelines, that they may be able to figure out what that risk is by measuring, Lp(a). And then I think it is an impetus for further research now that there are agents out there that selectively lower Lp(a), to do big randomized trials and really prove in the kind of, standard way that we tend to prove these hypotheses whether the Lp(a) lowering actually matters. I think it's basically an impetus to do these randomized controlled trials, and there's some very exciting agents, out there right now. For example, there is an antisense, mRNA that really shuts down Lp(a) production, and so you get very large Lp(a) reductions, and it's selective, so you don't have to sort out, how much is LDL and how much is Lp(a), and so we're definitely looking forward to those large randomized trials.